Everybody, Dr. Kruger here. It's my distinct pleasure to introduce my colleague for today's Grand Rounds. Dr. McClave and I have known each other for a long time. In fact, the first time I called him, I was junior faculty down in Alabama, and I called him and asked him how he managed to do a nutrition trial on a person with severe pancreatitis at the time where we used to starve people with pancreatitis. So Steve graduated from Ohio State, MD, and then went on to MUSC in Charleston, South Carolina for internship residency, and then served as chief resident there. And then, like a lot of us in the South, he went on further south to South Florida, where he did his fellow in gastroenterology, graduating there in 1985. We were lucky to recruit him here at University of Louisville in 1985, and he's been here ever since. I won't try to read his CV because he has over 300 publications. He's internationally known for his work in nutrition and particularly guidelines. Every year he hosts people from across the country in a Nestle Nutrition Fellowship, which is an intensive 2-week fellowship. He does that twice a year. So he's extremely well known. I'm going to call him not a triple threat, academic, research, and clinician. I'm going to call him a quadruple threat because he's also an elite athlete, still runs a lot, cycles a lot, and so he's a quadruple threat. So please welcome Dr. McClave for his presentation today, The Changing World of Obesity Medicine.
Thank you, Chris. Got it. Yeah.
Don't forget that.
Yeah.
You turn on.
Yeah, I did. Yeah. Good morning, and thank you for joining us virtually and on this late notice. This is a topic that I don't get to talk about very often, but the reason we're talking about it today is because obesity medicine has become such a big part of nutrition medicine. These two worlds are converging in training and in knowledge and in management of patients. For what it's worth, I am boarded as a physician nutrition specialist. Chris mentioned our Nestle Nutrition Fellowship, in which faculty from all over the country come into Louisville for an immersion course, 2 to 4 weeks. And we have a wide curriculum that goes from healthy eating, wellness promotion, to obesity, to hospital-based and parental nutrition. You can't even be a mediocre nutritionist without being cognizant of what's going on in obesity medicine. And the excitement in the past year is over the top, and that's what I hope to share with you this morning. I have 3 objectives. One is to understand the impact of this new class of drugs, these glucagon-like peptide or GLP-1 receptor agonists, and how it's changed the practice of obesity medicine. We need to appreciate that this has caused a dilemma for our practitioners who have to balance, do we still push lifestyle intervention measures, or do we just slap them on the pharmacologic agent? And then finally, to appreciate this evolving paradigm that obesity is a chronic disease and leads to other chronic diseases. That's called the ABCD, Adiposity-based chronic disease concept. And these are my disclosures. What's new in obesity? It's this explosion of the incretins, the GLP-1 receptor agonists. This has taken place over the last several years, but it's just seemed to have exploded in 2023. And just in the last 6 weeks, we've become aware of 2 studies that indicate the cardiometabolic context of these drugs, that these drugs can actually, in addition to treating obesity, are going to reduce the risk of cardiovascular disease. We've seen an incredible expansion of training in obesity medicine. I'll share that data with you. And then this has impacted the future role of everything we've done in the past with obesity medicine. How do we handle the lifestyle intervention changes? Do we still keep pushing those or not? How has this affected industry? Obesity is a huge industry out there, and that's undergoing change. I mentioned that there are management dilemmas, and these have not all been worked out. And then where does it leave bariatric procedures, both surgical or endoscopic procedures? What certainly lit the flame, a fire of this exploding information is the release of semaglutide, which undergoes different names depending on what they're treating, Wegovy, Ozempic, Rybelsus. This is a GLP-1 agonist, and you ramp up the dose as you place a patient on these agents because there's a tolerance issues with the nausea. The full dose for obesity being 2.4 milligrams sub-Q weekly. The side effects are mainly the nausea that you're dealing with and some diarrhea. The trials with this drug have been published in 5 major high-profile journals. This one in New England Journal showed that the weight loss from semaglutide over 68 weeks, just a little over a year, was close to 15% versus placebo at 2%. The weight loss from this agent was nearly twice that what we've seen with all the preceding agents. And if you look over here at the lower right-hand corner, 70% of the patients lost 10%. That's kind of been the mark of success in the past. Half the patients got 15% weight loss, and a third got a 20% weight loss. To put that in perspective, that's approaching the weight loss that we'd expect from a gastric sleeve. So that is why we're seeing such excitement about this drug. Tirzepatide is a combination agent where they added GLP-1 to gastric inhibitory peptide, GIP. Mounjaro is the brand name of this. This has been approved for diabetes, and we expect it to be approved for weight loss over the next academic year. The weight loss with this combination agent is nearly twice what we saw with semaglutide. So if semaglutide on the average was around 12%, we're seeing weight loss of 21 to 23% with this combination agent. And there are more drugs in the pipeline. I'm sitting here getting ready to hear the talk and have heard of a triple agent with 3 agents involved, and they're talking about 30 to 40% weight loss. Just an incredible pipeline of agents that are still coming out. This is one that caught my attention, bimagrumab. This is a monoclonal antibody that blocks a receptor, an activin type 2 receptor. And this promotes muscle growth, but it also causes beiging, in which white adipose tissue shifts its phenotype toward a brown adipose tissue. Doesn't quite make it all the way there, and that's called a beige adipose. This type of adipose tissue has an uncoupling effect, which means that oxidative phosphorylation is screwed up. And you get an increased energy expenditure because you have to go through the Krebs cycle more often, and that leads to weight loss. But it also is anti-inflammatory. It affects macrophage phenotype. So it converts M1, which are pro-inflammatory macrophages, to M2 macrophages, which are macrophages of resolution. They're anti-inflammatory. It does that while promoting insulin sensitivity. It promotes clearance of lipids and glucose, which means there's decreased toxicity from hyperglycemia and lipid deposition and increased utilization. And it does all that while it increases muscle mass. So over here are the studies from this study down here at the bottom, in which over as little as 24 weeks, half a year, the fat mass is going down while the lean body mass is being increased. And you just can't imagine the myriad of benefits from these agents. And just in the last 6 weeks, we've seen 2 studies come to fruition or come to our attention about the cardiometabolic impact of semaglutide. And this is pretty impressive. The first has been published, and that's the STEP heart failure trial, in which they had a little over 500 obese patients with congestive heart failure. They had what they called preserved ejection fraction. So it's abnormal, it's below 64%, but it's above 50%. So they have some preservation. They were put on semaglutide at full dose, 2.4 milligrams for a year versus placebo. They had a Kansas City cardiomyopathy score. The higher the score, the better the function, better the output, better overall cardiac function. That score went up by 16, almost 17% on the drug versus half that on placebo. The change in body weight, a 13% drop in body weight compared to 2% on placebo. And look at the 6-minute walk. This is a standard test we would use to look for frailty. 1 meter with placebo, 21 meters with 1 year of semaglutide. But the one that has not been published yet, but the manufacturer, this Novo Nordisk, sent this out as a pre-publication announcement. This is the SELECT trial, over 17,000 patients over many countries, something like 100 or 200 countries were involved. These were patients who are obese with established cardiovascular disease, placed on the drug versus placebo for 5 years. The dose was semaglutide weekly. 80% of these patients were already, they're established cardiovascular patients. They're already on aspirin, statins, ACE inhibitors. What they saw was that the 5 years of semaglutide resulted in a 20% reduction in major adverse cardiovascular events. We're talking non-fatal MI, non-fatal stroke, and cardiovascular death. So this is a whole area of benefit from this drug that's just emerging. With all this information, this has changed a lot of our strategies in approaching these patients. First off is the role of lifestyle intervention. Is that still important? Do we get enough benefit from that? It's labor intensive. Compliance is an issue. A lot of demands placed on the patient. Do we just forget it? The side effects from the older drugs now limit their use, and these drugs are just pushing them right off the stage as we get into these newer drugs. Liraglutide, which was the first GLP-1, was a daily injection. So just moving to a weekly administration with the semaglutide kind of trumps that, and I don't think we'll see much more, a lot more of liraglutide. There's an interesting relationship. The FDA made sure that the manufacturer emphasized that there was some risk with these agents with a medullary carcinoma of the thyroid. But it turns out it was in mice only. So it's a theoretical risk, but Novo Nordisk agreed to acknowledge the risk if the FDA would kind of expedite the approval of the drug. What this means is that the risk is probably pretty darn low. You don't need to check neck ultrasounds or monitor calcitonin levels when they go on this drug. You just probably don't want to use semaglutide in a patient with known medullary carcinoma of the thyroid or with MEN1 syndrome. But remember, any concern for risk of that cancer is offset by the fact that their weight loss is going to reduce their risk for 13 obesity-related malignancies. We've already seen evidence in these agents that combining agents, that tirzepatide, the GLP-1 plus GIP, allows you to reduce the individual dose of each agent and reduce the potential side effects. Another crazy thing is these pharmacies that compound their own semaglutide. These are usually foreign pharmacies. Singapore is a big source, Mexico, Canada, and they can they can do that very cheaply, from $1,800 a month with the FDA approved drug. They can get it down to $100 to $300 per month. But talking to some of my colleagues in endocrinology, they say this just, we shouldn't promote this at all. Patients will do this on their own, but we shouldn't be promoting it because sometimes we don't know if these drugs have been adulterated. The dosages are a little off sometimes. They're not monitored by USP. They're not approved by FDA. And then there's a whole nother crazy area of the benefit from these drugs, and that may be in the treatment of alcohol abuse syndrome. The anecdotal experience with people on semaglutide, they don't drink as much. They don't like the taste of alcohol, the little nausea that they're dealing with. They just don't drink as much, which means that we may see in the near future randomized trials where use of these agents reduces or helps treat alcohol abuse. So where do we stand with lifestyle intervention? Does it work? Is it worth it? Do we keep pressing it, or do we blow it off? It's complex. Remember that it includes smoking cessation, stress reduction. You need to be happy. Exercise, sleep hygiene, moderate use of alcohol, of course, healthy dieting, and weight loss. If we look at the early studies with diabetes, it worked. This was the diabetes prevention trial. That was 20 years ago, in which lifestyle intervention was compared to metformin and placebo. And sure enough, the greatest degree of weight loss was seen in the lifestyle intervention. But what was more interesting was if you looked at these three measures, metformin, placebo versus lifestyle, in preventing diabetes in the future. And this is, we're talking 4 years out. Metformin reduced that risk by 31%, but lifestyle intervention doubled that and reduced the risk of ever getting diabetes by 58%. And in this diabetes prevention, we were talking about diet therapy and moderate physical activity versus the controls that just had like 3 symposium over the course of a year and just were educated about these principles. Here's another, the Look Ahead trial, looked at lifestyle intervention. And here they're talking again about diet restriction. Here they specified or tried to get 175 minutes of moderate exercise a week. Controls, again, just went to a symposium and passed out or educated, but not monitored closely. And what we learned from the Look Ahead trial was that about 11% of patients are going to achieve that kind of standard landmark of 10% weight loss or more. And that will occur over the first year. But then they start to slide, and there's this issue of sustainability. That's when, in the past, we would hit them with a second strategy, i.e. a pharmacologic agent. And that combination, and here we're talking about Kismia, which was the best drug we had before the incretins. The combination of the drug with lifestyle intervention, we picked up another 50 to 55% of patients achieving that 10% weight loss. So now we have 11% plus 55%. That's 2/3 of the patients are going to get to that 10% weight loss mark with a combination of lifestyle and drug. The last third that still didn't respond to these two strategies, then they would require endoscopic or surgical bariatric procedure. But there's a lot of issues now. This is older information. We don't know what these new drugs are going to do. We know they're a lot stronger than Kismia, so we would expect maybe more patients to achieve this weight loss. But we also know anecdotal experience, and this is talking to one of my endocrinology buddies at Mayo Clinic, Manpreet Mundi. He says if you look at patients on semaglutide, at the end of a year, only about 1/3 of them are still on the drug. They stop because either the insurance stopped and they can't afford it, they can't tolerate the nausea, or they've lost enough weight that they're there, that their ship has arrived, they're fine, and they go off the drug. So all this is up in the air as to how successful these drugs will be added to lifestyle intervention. But here's another study to just reinforce that we don't want to completely forget about lifestyle intervention. This was a trial published in New England Journal looking at liraglutide, that first GLP-1, plus or minus exercise versus exercise alone versus placebo. Over the course of a year, the patients randomized to placebo, their weight drifted up. The ones that did exercise alone were kind of weight neutral. Liraglutide was associated with some weight loss, but the combination of exercise, lifestyle intervention, plus the drug was associated with the greatest amount of weight loss. So again, these studies reinforce that you're going to get added benefit with lifestyle intervention. But that we still have this dilemma now that are facing our practitioners, and that is, do they take the high road? Do they continue to push lifestyle management, which takes infrastructure? It's can be cost prohibitive, labor intensive, compliance is an issue, and then only add the pharmacologic agent as needed? Or do you take the low road and just slap them on the drug and hope they exercise more? Ironically, in that situation, their lifestyle choices may get worse. They have this mentality, oh, I'm covered by the drug, I can kind of eat and do what I want. Another version of this dilemma was solved by, these are two different endocrinologists I'm talking to. The other one would solve that dilemma in this manner. For children, they're looking at a lifelong issues of behavior and diet, that you would continue to push them. They need to be educated on what to eat, how to cook, how to exercise daily and work it into your schedule, and only add the pharmacologic agent as needed. Adults, take the low road, go straight to the drug, and just don't forget lifestyle, but don't push it as hard. As far as the agents we've had in the past, really, I think they're old school. And when you look at the agents and their side effects and all the caution we had to use in patient management, Kismia was a combination of phentermine topiramate. You couldn't use it in hypertension, heart disease, or if a patient was pregnant. Contrave, a combination of naltrexone, bupropion. You couldn't use it if they had hypertension, seizures, if they are already on an MAO inhibitor, if they had anorexia nervosa, or were going through substance withdrawal. Belviq was a 5-H2 agonist. You couldn't use it if they were depressed on SSRIs. If they were pregnant, you could use it with caution in heart failure, but they had to watch it closely. Liraglutide, that first GLP-1 agent, really the only thing you had to worry about there was abdominal pain and whether they might get pancreatitis. A very low number, maybe 1 to 3%, but that's what you're worried about. These agents really now, with these new agents, these guys, this is probably old school and are moving off the stage. The impact on industry is really interesting. Jenny Craig, which has been around for decades, closed shop in the last year. These drugs are out. We don't need Jenny Craig anymore. They closed their doors. Weight Watchers did a very interesting thing. They are in the process of acquiring a national telehealth company. Their goal is to have MDs that can virtually do virtual office visits and prescribe the drugs. And then I've heard, this is a rumor, I don't know how the truth of it, that they're actually working to get the distribution rights for semaglutide so they can control the supply line. There's an impact on nutrition fellowships. It gets back to this overlap where obesity is such a big part of nutrition medicine and vice versa. 10 years ago, we had 12 year-long fellowship programs in clinical nutrition. In this academic year, we are down to 6. And of those 6, 2 have already said we're not really the traditional nutrition. We are now obesity medicine. You'll learn a lot of nutrition, but we are formally now an obesity medicine fellowship. There are 2 more available in Canada. Others are struggling to get financing, or they've already just changed their format. But what's amazing is this industry-sponsored grant program that has caused an implosion of training centers. This was this Obesity Medicine Fellowship Council, and it was formed 5 years ago after Novo Nordisk, the manufacturer of this drug, established this grant program. And basically they said, what we'll do is we'll come to your center and if you apply for this grant, the grant is $100,000, which pays the salary for a fellow for 1 year, if the institution agrees to fund 5 more years to train 5 more fellows. Before this fellowship or this grant program was announced, over 20 years, they had 9 programs in obesity medicine, training a total of 47 fellows. In the 5 years since the grant, 15 new programs have trained 76 new fellows, physicians trained in obesity medicine. Years ago, in 2001, nutrition applied to the American Board of Medical Specialties so that nutrition would be a specialty of its own in medicine. And it got voted down. And they said, if you want this to be approved, you have to have 1 exam. You have to have over 200 physicians take the exam every year, and you have to have a year-long training to prepare for the exam. Nutrition never made that, but obesity medicine has. Basically, they've tapped into 2 different groups that take their exam. The board was established 10 years ago, but medical, non-surgical MDs, practitioners are a group taking the exam, and then bariatric surgeons who have to get recertified to maintain their center of excellence, they take the exam. So they easily get over 200 a year. We now have 24 training centers available for a year-long fellowship, and there's 1 exam in obesity medicine, which means that it's just a matter of time before the ABMS recognizes them as their own medical specialty. The other concept that's emerging, and this is Tim Garvey and Jeff Mechanic, one of my buddies, is this chronicity of obesity and how it leads and increases risk of other chronic diseases. This model is called ABCD, Adiposity-based chronic disease. So in your practice, you may be aware of a person, young man or woman, who's at risk for obesity based on genetics, his environment. Here you hope They may have pre-disease. They may be already showing signs. They may be overweight. They're not obese yet, and they're having problems with insulin sensitivity and prediabetes. Here, public health mentioning, social programs, physical activity, these are going to help you prevent the progression. Because if there's nothing to intervene, then they'll develop obesity, and now they do have problems with prediabetes, dyslipidemia, metabolic syndrome, steatosis in the liver. Now you're going to have more weight loss, physical activity. You're going to have to treat the dysglycemia. If that progresses, then the obesity increases your risk for all these other chronic diseases, heart failure, cardiovascular disease, stroke, hypertension, clinical diabetes, and NASH. And now the weight loss has to be more. Now you have to start them on cardioprotective, renal protective mechanisms. The key is in the past, we've been BMI centric. If BMI reaches this point, then we can start thinking about drugs. Get a little higher, we start thinking about bariatric stuff. This model says you need to think a lot sooner, intervene sooner if you're going to turn this chronic process around. Don't discount the influence of genetics. It's estimated that 85% of the population is at risk for obesity. I cannot find where we got this, but it's repeated repeatedly. We know that 70% of the US population is either overweight or obese. And people are saying, well, finally, the epidemic is leveling out. It's leveling out because there aren't too many people left who are at risk that aren't overweight and obese. Example of this is that the guy in the Super Size Me movie ate 3 meals a day at McDonald's and gained 20 pounds, became hypertensive, hyperlipidemic, and his liver enzymes, his transaminases, went up to 500. Contrast that with the 15% of people in our population that may be protected from obesity. This is the famous Don Gorski from Fond du Lac, Wisconsin. This guy has OCD and he works at a prison, and every day eats lunch and has 1 or 2 Big Macs. And he's been doing it for over 40 years. He's up over 30,000 Big Macs. He is 6'2". He has a BMI of 23.5. So somehow he is protected. My wife and I were on vacation. We were ironically in a McDonald's, and the person behind me had a sports jacket, Fond du Lac Warriors. And I go, is that Fond du Lac, Wisconsin? And he puffed up his chest like, oh, you've heard of our Warriors where you're from? And I said, do you know Don Gorski? He goes, oh, God, yeah, everybody knows Don. Is that right? It's like 1999. This is the box that they got. Oh, my gosh, if you didn't hear that, he says that he stores the boxes he ate the Big Macs with at his home and labels the year. The parabolic increase in our obesity epidemic took off in the last century, and it's been attributed to kind of a perfect storm of 3 factors. One is energy-dense food, fast food, trans fat, high fructose corn syrup. Fructose is just practically poison when it comes to obesity. Larger portion sizes and decreased physical activity. Now, this picture down here are these genetically modified chickens, big boy chickens, to increase the weight of their breast meat. And they're so heavy that their legs break spontaneously because they can't sustain the weight. This picture up in the upper left-hand corner is from that movie WALL-E, in which humans got so obese they got to the point they just floated around in chairs because they could no longer walk. But what's scary to me are the agents in our environment called obesogens. And this has been just exploded Matt Cave's career. These are agents out there in our environment. Originally, they were called chemical toxins. Very early, they were called endocrine disrupting chemicals. In 2006, they coined the term obesogens. And then Matt's career took off when he identified TASH, toxin-associated steatohepatitis, in 2010. The latest term is metabolism disrupting chemicals. And what these are agents in our environment. A lot of them are called forever chemicals. They never disappear. PFAS and DDT are 2 examples. A grandmother exposed to DDT can cause obesity 2 generations in the future in a grandchild. What they do is they alter epigenetic signaling. These agents can raise your set point and cause a patient to become obese. And they're everywhere. They're in food production, the farmers spraying stuff on their crops. It's in industrial activity in which these agents leak into our water supply and our air supply. Personal hygiene products, medical medications, and the containers and the tubing in the medical supplies are all sources of these agents. And these the mechanisms by which they work are multifactorial, and this is contributing to obesity. And set point has become just a fact of obesity. And this is not me saying this, is Tim Garvey, is a quote from a paper last year. The set point is an essential and persistent aspect of the pathophysiology of obesity. The worst thing you can say to a person who takes care of obese patients is, oh, you're a Kiko. Kiko means you think that obesity is just related to calories in versus calories out. If they just push away from the table, they'd be a lot better. Well, those people are idiots, because it is so much more complex than that. A patient at the patient interface with energy coming in, energy going out, there are biological factors. What was the in utero environment? Was the mother a heavy eater or obese herself? Gender, concurrent disease, their birth weight. Genetic susceptibility and epigenetics, and how agents in the environment can turn on and off epigenetics that promote obesity. Food quality and availability, food deserts, food swamps where the food's available but is poor quality. And then individual behavior, their diet, their physical activity, access to healthcare, all these things interface. And the body ends up with a set point where it's going to try to maintain your weight. And the discouraging thing is, it looks like at this time that it's not currently curable. Well, what do I mean by that? The set point is, there's two ways, a couple different ways to look at set point theory. One is that somebody told me it's like if you're close to your ideal body weight and you have an apostat, and the apostat is comprised of these satiety, hunger hormones, and if you starve or are not getting to eat, it increases hunger. It may even decrease metabolism if the starvation goes long enough. And that helps bring your weight back up to the set point. If you eat too much, it suppresses hunger. It may actually increase metabolism. That brings you back to that set point. So one perspective is that the apostat, when you're obese, is broken. Another aspect to look at is shown here below, and that is when you lose weight, alarm signals kick in that drive you to eat and get you back up, because that's not tolerated if you're a caveman out in a harsh environment. If your weight drifts up a little bit, really there's no alarms go off. But if you then try to lose weight a second time, alarm signals kick in a second time. The point is that the weight can drift up, the set point can drift up. It's very hard for the set point to drift down. And that shifting is called settling of the set point. What's what causes this? What is this broken apostat? Well, these are a description of the major hunger and satiety signals. There's only one hunger satiety, ghrelin, and the rest are satiety signals: pancreatic polypeptide YY, pancreatic polypeptide, GLP-1, leptin, insulin. When I look at these, I think, if I were obese or my patient was obese, what would I want out of this hunger satiety signal? And that way it tells me what's broken in obesity. So hunger is ghrelin. If I was obese or my patient was obese, I'd want those levels to be lower. And they are. So that's a nice, appropriate response. The problem is when you eat a meal, ghrelin should just drop like a stone. And that's what's screwed up in obesity. There's loss of that postprandial decline, and that's inappropriate. PYY is probably one of the prominent or best satiety agents. If your patient was obese, you'd want those levels to be higher to stop them from eating, but they're not. They're actually lower, which is inappropriate. And when you eat, they should rise to keep you from eating more, to stop you from eating. And that postprandial rise is less, which is inappropriate. Insulin and leptin are both satiety agents. If your patient was obese, you'd want the levels to be high. And they are. The problem is the receptors don't work. Adiponectin, which is not really a hunger satiety signal, but I call it a dream cytokine. It does everything else. It burns fat. It raises energy expenditure. It stops you from depositing fat in the viscera, and those levels ought to be high. That's what we'd want from it. But in obesity, the levels are inappropriately low. So this is the actual evidence or the mechanism how this apostat is broken. How do we know it's broken and how long does it stay broken? Well, this is the data that's frustrating. You remember the Biggest Loser TV show? They went back to the group that came through in 2009. There were 14 of them. And they came back 6 years later and evaluated them. And all of them had gained weight except for 2. So this is a graph of the weight gain. And only one patient continued to lose weight after his weight at the end of the show. Another one gained weight, got a bariatric procedure, surgical procedure, and weighs less or maintained weight off. Everybody else gained weight. So an average of about 58 kilograms was lost over the 30 weeks of the show. 70% of that was regained over 6 years. So there are biological forces, there's biological pressure pushing them back up to that set point. And this caused a guy named Lee Kaplan at Harvard to make this statement, and think about this closely. It is not that you're fat because you eat too much. It's you eat too much because you're fat. It wants to drive you back. The biological pressure is going to cause you to eat more because you're fat in the first place. A disturbing study with semaglutide, it was published in JAMA, in which they started patients on semaglutide full dose, and at the 20-week mark, they randomized them to stop the drug or continue on. So at the 20-week mark, they'd already lost 10% weight loss. That beats Kismi and all the agents before these GLP incretins. The group that continued on semaglutide lost another 18%. So we're another 8%. So we're talking about 18, 19% weight loss. The group that went off the drug gained 7% weight gain. This suggests that you go on semaglutide, it needs to be a lifelong commitment, and you go off, you'll just lose it. It also suggests that these set point mechanisms remain operative despite lifestyle intervention, weight loss, and medications. And that's frustrating. If you stand back and compare these new agents with the agents in the past and what we can offer with endoscopic and bariatric procedures, Kismia was the leader in the past, which was associated with about 7 to 8% weight loss. Average with semaglutide is 12%. This shows the comparison. Semaglutide is almost double what we saw with the previous agents. The tirzepatide combination is almost double again at 20%. When you get to 20%, now you're in the range of a vertical banded gastropathy or a sleeve procedure. You're still not yet in the gastric bypass, but some of these agents that are coming down the line that get up to 25, 30, 35% weight loss will start to encroach on the areas of success from bariatric surgery. What about the endoscopic procedures? The Aspire Assist is that deal where you basically put in a peg, and after you eat, you just go in the toilet and drain it. The problem there is you have to eat kind of slurried food to make that work. The balloon systems, these duodenal sleeves that give you a period of malabsorption or segment of malabsorption. The weight loss in these agents range from 6 to about 10, maybe 12%. That's easily within the range that we're seeing with semaglutide. We have the endoscopic stitching here to create an endoscopic sleeve. That's going to approach the numbers that we would see with a surgical gastric sleeve. The question is, these new agents, what kind of impact are they going to have on these bariatric procedures? And here we're concerned that they're going to starve. Nathan Liu is a phenomenal endoscopist here. He hit me up several times for extra dollars. The bariatric surgeons, how are they going to feed their family? This is being ridiculous, but it makes it, what's the future? I think in biggest jeopardy are the sleeves. Bariatric bypass is probably still firm place in our management, but these drugs are giving them a run for their money. We don't expect to really feel the impact or see the impact probably till the end of this academic year. Don't discount a patient that loses weight and then gains some of it back. because any weight loss is a benefit. This looks like the curves I showed you early in the talk, but that was at the 4-year mark. They came back and took both the diabetes prevention and the look ahead trial and took it out to 10 years. And look at this. This is the group that got lifestyle management, and their weight continued 10 years out, was still lower than placebo and matched what you'd get from metformin. And the prevention of diabetes, the intervention, lifestyle intervention, again, the greatest reduction in risk of diabetes, metformin next, and placebo was the worst. So there's some benefit, even if they regain some of that weight back. But what we're learning is that increasing degrees of weight loss may be required to disrupt that ABCD, that adiposity-based chronic disease. In other words, we'll see a reduction in inflammation with as little as 3% weight loss, a reduction in risk of diabetes. Maybe we start to see it with as little as a 7% weight loss. On this graph, this gray box is the range of results that we would see with semaglutide. So when we get into that range of 10 to 20%, now we can influence physical function, that's degenerative joint disease and sleep apnea. We can affect clinical diabetes, risk reduction in cardiovascular disease, hypertension, and NASH. Remember that semaglutide averages 12%, but half get 15%, a third will get 20%, and it puts in the range where you can really impact these diseases even after they're in tertiary prevention and clinical disease. So in conclusion, if you stand back and look at where we stood and where these new agents come in, lifestyle and the previous medications had the least amount of weight gain, about 10%. Endoscopic procedures and bariatric procedures increased that amount of weight loss. Surgery clearly is the only mechanism here where we may permanently alter that set point satiety hunger signals. But semaglutide is coming in at 12%. Tirzepatide at about 21, 22%. The newer agents, combination agents, may get us down closer to 25, 30%, where we're even encroaching on the gastric bypass. And in my last question, and I put this out, and I'm going to stop. Who should be placing these patients on medications? Every time we sit there in GI clinic and we have an obese patient in front of us with GERD and NASH and fibrosis, we want to say we got to start them on semaglutide. At the Mayo Clinic, they have 300 to 400 people on a waiting list. It takes 9 to 12 months to get them into an endocrinologist. You can vary a subspecialty with the need these patients have. So I'm going to end up with this: what infrastructure is needed? How do we manage this? Certainly primary care. We have tremendous talent on this campus through Sri Moshe Gundam, Satya Krishnaswamy, Bridget Heidepol are out there in the trenches. And how can we work together as a university and meet this need? So I'll stop there. Thank you very much for your attention.
That was brilliant, Dr. McClave. If I can do the first question, Dr. Kruger.
Sure.
So I guess everyone knows that I only have two concerns, and that's nutrition prevention and health equity. You've given me so much more information about the nutrition prevention side. That was just really a fantastic review and so informative. So, of course, my question is about the other side. When you have the pricing of agents like this, like what we're seeing, isn't this going to increase our health inequities? Because the people who have insurance and a good policy can get them. They may be told which drug they can have based on some contract that the company has with some corporate entity. But our poor patients are really struggling. And we try to get them pre-authorized and we try to get them support, but they're not going to have access to these medications. What do you see if you're reading the tea leaves, and we know that obesity is a bigger problem in our folks who have socioeconomic depression? How can we navigate on this?
I don't have an easy answer, but you hit on something earlier on when I said these pharmacies can compound this at a fraction of the cost, $100 to $300 versus $1,800 a month. And we shouldn't do it because they're sources that we can't fully trust. But it highlights what you just said, and that is that incredible health inequities. Things are screwed up in this country that these drugs are so expensive. There's supply line issues, and it just highlights the predicament that we're in. And you're right, the people that probably need this the most are the ones that are least advantaged and are going to have the least chance of getting on these medications. It's a great point.
Well, thanks for that. I think it's an opportunity for legislative advocacy, and just think of just project the downstream savings to our healthcare system if we could take care of obesity in the poor.
Yeah, I mean, look how obesity touches so many other disease processes, and catching it early. Not waiting for the BMI to be the touchstone to start therapy. That we look at the overall pattern of risk and intervene earlier, and then legislation to help control. Part of me watches as benefit after benefit comes out of these drugs, and this manufacturer must just be just enjoying every minute of this. And why can't they lower the cost? Nathan, you had a comment there.
More cost-effective medication, and Medicare, Medicaid understands this, so they're actually the first people to approve the procedure and pay for it. Actually,
wow.
So your Medicare, Medicaid patients actually are the first ones that will benefit from bariatric endoscopy, and we're more cost-effective at 3 years long. So that's when the studies show we will have longer lasting effects.
If you couldn't hear that in the audience, Nathan Liu points out that Medicare, Medicaid now is supporting the cost of bariatric endoscopic procedure sleeve because it's cost effective 3 years out compared to continuing on with these expensive drugs. So that's a great point. That'll make it more available to lower socioeconomic groups.
Prohibits approval of any weight loss medication in Kentucky Medicaid. So the first step that we are trying to work
Are you
through
kidding?
is to get that law repealed before they can even consider
Yeah.
So that it is a challenge because there is a law that specifically was passed in the 1990s. I think after all of the maybe the Hudax fiasco, I don't know what it was, but that specifically prevents any weight loss medication.
Unbelievable. How many states are?
It is Kentucky Medicaid.
For sure. Yeah. Oh, that's terrible. That's terrible. Yeah. Mm-hmm.
One was says many people lose and gain weight a few years after bariatric surgery. Might this happen with drugs?
Like you develop a tolerance, or you lose effect while you're still on the drug. Yeah, yeah, go ahead.
Patient that had a wide gastric bypass.
Mm-hmm. Yeah, come on up here.
So if you have a patient that had a Roux-en-Y gastric bypass and they lost weight initially, and then they start gaining a bunch of weight, they need to have an EGD, because it may not be their fault. Their stoma, from where their stomach connected to their jejunum, may have widened. And if it's above 20 millimeters, they have no gastric pouch. So when they eat, they get dumping syndrome, and then they never feel full. And it's because the pouch widened. And so they need an EGD for us to evaluate to see if they have a gastric fistula, or if we need to do an endoscopic procedure to tighten their Roux-en-Y gastric bypass, which is also new, that just got approved this past year. So if you have a patient that has a Roux-en-Y and they're gaining weight now, please send them for an EGD, probably with me, to evaluate if maybe we can help them lose that weight. Because patients that have a Roux-en-Y, they have gone through all of the means to lose weight, meaning they have had multiple months where they've done dietary lifestyle interventions. they made a huge change, knowingly doing a major surgery that would drastically change their life. It's not just that they have slipped up. So obviously, maybe some people are just eating again, but there may be an anatomical issue that's causing this that we can actually fix. So I always tell patients, don't blame them. Let's see if there's something that we can fix after they've had a bariatric surgery.
Yeah.
So
that's great comments, Nathan. I want to come back to that in a minute. I haven't seen any evidence yet that there's a tachyphylaxis to the drugs. I think that's what the question might have been getting at. We just don't have enough experience yet. And remember that 2/3 of patients are going to come off the drug for a variety of reasons, which would, of course, result in weight gain. Oh, yeah. All right, Loretta.
Dr. McClave, I heard on the radio a national law firm appears to be organizing a class action lawsuit for side effects, namely gastroenterology, with posing problems to the fate of the class of drugs.
I haven't seen specific data on the incidence of documented gastroparesis. They're out there. The nausea is a constant problem. When I talk to my endocrinology buddies, they say it's fairly easy to treat with Reglan, to some kind of dietary gastroparesis dietary manipulation. It's fairly easy to manage. Some have to go off the medication. Whether that causes permanent gastroparesis, I have not seen data that says that. Yeah.
There are some cases out there that
I think it's a small number, but we don't know yet because we haven't had enough experience.
One more check.
Sure.
Actually, so David Armstrong, our rheumatologist,
Mhm.
knows that any recommendations for a patient with PCOS who has not lost weight with metformin or Ozempic.
Well,
Polycystic ovary.
yeah. Oh, yeah. Would you go to another drug? These drugs, are you using tirzepatide off-label, Shri? In other words, for obesity?
Sometimes the insurance approve it, sometimes they don't. That's the problem.
Yeah.
There's a recent article in Nature on the GLP-1 receptor polymorphisms, which determine whether or not to respond to the
Mhm.
So they showed that there are people who do not respond.
Yeah.
And so they have looked at it, found that the surface receptor, there are variants which
Just don't go respond. But that would be a selling point for the newer agents with combination multiple agents to go to.
So Steve, you showed literature on the overall weight reduction with lifestyle versus bariatric surgery versus these chemicals, these medications. We need to have more head-to-head, don't you think, trials for appropriate patient selection to take into account maybe their polymorphisms, maybe their economic status, because I think in the end, it's going to be everyone trying to do all these things, and we don't know which would be better for the individual patient. How does a primary care doctor select, which would be the best road? And the next question I have for you, because it goes way back to something you mentioned about your set point changing when you lose weight. There's lots of anecdotal reports about intermittent fasting. And my question is intermittent fasting for 12 or 18 hours or 20 hours going to change your set point and be another lifestyle type recommendation for those that can't get these drugs?
Yeah, that's great series of questions. And let me go back to the implication that you said would say we should keep reinforcing BMI, that we have to have signposts along the way to say, okay, now we do this, now it's gone further, we're going to need to do that. But that's actually been criticized because you have a patient who comes in, he's 16 years old, he's already overweight, his parents are obese, they have low socioeconomic opportunities. That's a guy or man or woman, you're going to want to intervene earlier and be more aggressive, and don't wait till the BMI gets higher. So it's kind of it's not the Wild West, but these are some of the questions we don't have. Another thing is fasting works. black and white, and there's benefits there that supersede the weight control. But a lot of the diets work. They just work up to a certain extent, about 10 or 11% weight loss. And then you're going to need to intervene with something else to pick up the rest of the population. But don't discount.
Most of these things, again, lead to weight loss with loss of lean body mass also.
Right.
Including bariatric. So I think it would help to just not forget the lifestyle
Yeah.
Yeah, Matt, you were going to say something about sarcopenia or how to keep your muscle up. You're the guy.
Yeah, this is not working.
Biggest loser, biggest loser, the metabolic parts. And so he actually, your set point changes with lifestyle modification, but it changes in a way that makes you regain.
Yeah.
So the biggest loser had to eat 750 calories less per day to not regain weight. So you imagine that compared to somebody else in the same weight. That's not to lose more weight, that was just not to regain.
Yeah.
So the difference is with drugs and bariatric surgery is the your baseline caloric needs you don't have those swings. So you're not doing the failure. So you take a drug or get a bariatric surgery, you don't have anything. You have to eat 700 calories less to not regain.
Yeah. I actually saw a number from that study that for every pound weight loss, it's an 8% reduction in your energy expenditure. So you're right. You lose weight, you just don't need as much calories, and it's hard to control that with eating less alone if you don't add exercise to make up that difference.
So the great thing about this, Steve, you can probably remember about 25 years ago, the nutrition societies all got together at 1 week to highlight the importance of obesity because nobody in the United States recognized it. So it's come a long way. But my question relates to sarcopenia. So people forget about muscle and muscle metabolism. The muscle's important for metabolism.
Sure.
And in our cirrhotics, especially, you see in obese patients, you see sarcopenic obesity.
Yeah.
So that monoclonal antibody that you talked about initially
was huge.
Could be a incredibly important thing. What do you think about that?
No, I think it's great. And the recidivism has a net effect on body composition. So when you lose weight, you're losing lean body mass out of proportion to fat mass. When you gain, you're gaining fat mass out of proportion to lean body mass. So the net effect of this business is loss of lean body mass, increase in body fat mass. The study with liraglutide that showed that exercise with liraglutide helped maintain that body mass. The monoclonal antibody, same thing. So frailty is becoming such a big part of patient management. We had one of the Nestle fellows does work in frailty and cirrhosis, and she says that if you're frail, and you're cirrhotic, it's like adding 9 points to your MELD score. So focusing on measures to sustain and increase lean body mass is critical in all these studies. Great point.
Well, are there any other questions? I know we're all thinking real hard about how to maintain muscle, lose fat, and keep our patients safe, keep them. I think Dr. Williams will say if you just went out on the tennis court, you'd gain a lot because your muscle mass and your bone density would go up. So any other questions from the crowd?
Thank you.
Thank you very much, Dr. McClave. That was fantastic.
Thanks.
Thanks, everyone.